Maybe I'll just put the Kahoot link on the chat because I'm going to navigate away from this screen. Okay, good morning, everyone. Welcome to the lecture today on chronic coronary syndrome. My name is Ting. I'm from Khoo Hospital, and I am Dr. Doreen Tan's Tuti. Okay, so today we are going to spend time 1 hour and 45 minutes on this. Give me a moment, it's not moving. Okay, so I hope you have already gone through some of the pre-class activity, which includes the ebook as well as the video. And if you have time, you can actually look through the DPRO's chapter as well as the guidelines. Okay, so these are the learning objectives. You will want to know the learning objectives quite well because this is the basis on which we set the exam questions as well as the CLW questions. Okay, so do recognize that you have you need to pay more attention to the pharmacotherapy compared to things like the diagnostic test, for example. Okay. Okay, so some information on Kahoot if you have just joined us. Initially, I have wanted you guys to use your real names, but then Dr. Tan said that she'll get you guys to actually log in using your email her at the end of it. So if you never use your real name, it's actually okay. All right. So 5704855, and then the game pin is also on the chat. Okay, so I would like to start with the first question. If you have read the readings or gone through the e-learn, this should not be difficult. So your 67-year-old Uncle Sam says that his doctor told him he has coronary artery disease. He asked you what that means. You say A, B, you say there is a blood clot in your blood vessels that supply the heart muscles. C, there's a fatty plaque that cause narrowing of the vessels that supply the heart. Or D, there's a blood clot in the left chamber of the heart. Okay, so look through the options. I'm going to toggle to Kahoot right now. Okay, I have 49 participants. Anybody else who still want to join, please join before I start in the next 10 seconds. 9, 8, 7.
I think your screen is still on the PowerPoint.
Oh, okay. 5. Wait, just a minute. Okay, can you see the Kahoot screen now?
Still PowerPoint.
Still PowerPoint. Okay. And I'll just do one at a time then. Okay, can see?
Yep.
Okay, so I'm going to start now. Okay, so what do you say to him, your 67-year-old Uncle Sam? Okay, everybody has answered. Okay. Okay, most of you have answered option C, which is the yellow option. Okay, let's go back to the slides and then we will look through some of the content, okay? Okay, so there are different names of chronic coronary syndrome. It can be called stable angina. It can be angina pectoris. It can also be, some people say that this is stable ischemic heart disease. So there's been different names given to the this syndrome, and this chronic coronary syndrome is a relatively new name to this disease. So let's say if you read the readings, they might refer it to stable angina, or you read some of the guidelines, the older guidelines, they may refer it to stable angina as well. So what is chronic coronary syndrome? Is so CAD, chronic coronary artery disease, is a pathological process characterized by atherosclerotic plaque accumulation in the epicardial arteries, whether obstructive or non-obstructive. So I'm sure you're in the earlier lectures, some of your lecturers have already gone through with you. Atherosclerosis means that there's fatty deposits, okay, in the blood vessel, okay. So in this case, when the fatty deposits is in the arteries, epi means on the surface of the heart, okay, epicardial arteries, okay, the arteries on for the heart, okay. So when it is in the heart arteries, it's called CAD. Okay, it's a dynamic process because your disease can evolve and it can result in a couple of clinical presentations. It can be ACS, acute coronary syndrome, or chronic coronary syndrome, CCS. So today our focus would be on CCS. Okay, so this is the pathophysiology of the atherosclerosis. So when you're born, when you're just a baby, okay, your blood vessels are wide and open, no obstruction, no fatty deposits in the blood vessel, okay. Over the years, so the deposits, right, is said to actually start in the teenage years onwards, okay. So over the years, these fatty deposits actually accumulate, and you can see that at this point over here, okay, the fatty deposit is so huge, okay. So whatever blood that can flow through, right, is the lumen is very small, okay. So there is obstruction over here. That's why when this happens, when there is a lot of when the blood cannot flow through, it can cause exertional angina. That means when they exert themselves, they have chest pain. Okay, we'll go through that part of it later on. Okay, so in the event if there is a plaque rupture, okay, you see it says that plaque fissure erosion. Okay, when there's a plaque rupture, the natural reaction of the body is to actually form a blood clot over the area of the rupture. It's the same as, for example, if you have a wound, okay, if you accidentally cut yourself, your body will react by forming a blood clot around the wound, right? So in this case, the body doesn't know that this is actually inside the blood vessel, okay? Therefore, the blood clot forms inside the blood vessel. And when that happens, it has if it causes a complete, my apologies. If it causes a complete occlusion of the blood vessel, no blood can flow through, and this results in acute myocardial infarction. Okay, so that is when ACS happens, okay, acute coronary syndrome. But there are also times where there is no rupture. The fatty tissue continues to build up, and it causes a narrowing over the years, okay. And when there's no rupture, this is chronic coronary syndrome. All right. So back to our question. So in that case, our answer is C, and most of you have gotten it correct. Good job. Okay, so C, he has a fatty plaque that causes narrowing of the vessels that supply the heart. Okay, question 2. Uncle Sam asks you, how does atherosclerosis cause chest pain? You say A, B, This is due to acid reflux from the stomach. It flows upwards. And C, when you exert yourself, your heart needs more oxygen to keep up. But the plug is limiting the blood flow to the heart. That's why it causes the pain. D, when you exert yourself, the chest wall muscle has been overused, causing muscle damage. That is what causing the pain. Okay, so I'm going to toggle over to Kahoot right now, and you can answer the question from there. Okay, top on the list, we have hypertension. Good job. Oh, okay, actually there's a tie, there's 3 of them. High 1 and high 2. Okay, good job. Next. So second question, how does it cause chest pain? Okay, good. Right, good job. So everybody has gotten it right. So that is option 3 again. Okay, let's go back to the slides. Right, so C is the correct answer. So let's look at how we can explain to Uncle Sam the theory behind that, okay? So when there's chest pain, there is an imbalance between the myocardial oxygen demand and supply, okay? The demand would be, for example, if you need to exert yourself, if someone needs to climb the stairs, if someone needs to do if the person needs to do, for example, needs to run away from an enemy, okay? So the heart rate will increase, okay? Because the rest of the body will need more oxygen to supply the muscles for the increase in activity, okay? So in order to increase the demand, the body will have to, the heart will have to beat faster, increase in heart rate. So the amount of blood that's pumped out of the heart could be more per unit time. Contractility, how much your heart pumps, how hard your heart pumps with each contraction. Intramyocardial wall tension, which is determined by the amount of stretch. Okay, so if your heart muscle can relax and allow sufficient flow of the blood, it can pump more per unit time. Okay, so that is the oxygen demand. Okay, oxygen supply would be the amount of oxygen that supplies the heart. And the most of the time, if the patient if the person has no coronary artery syndrome problems, okay, then the patient would the person will have normal coronary blood flow, the heart rate, and the how frequent the heart contracts, okay, as well as the oxygen extraction and oxygen carrying capacity and coronary collateral circulation. All this will be able to meet the demand, okay, if there is no problems with the supply. Okay, however, in patients who have coronary artery disease, they have atherosclerotic plaque that blocks the supply, blocks the blood flow. Then when the demand increases, the supply cannot keep up. Okay, the amount which the blood vessel can dilate to increase the blood flow, right, to the heart muscles is fixed. Okay, that's why these patients will have symptoms. Okay, so there is an other form of chest pain that is similar to coronary artery disease. Okay, sorry, there is a typo over here. Is coronary vasospasm. Okay, so spasm means that there is, spasm, right, when the heart vessels actually suddenly contract. Okay, so when patients have an obstructing plaque, okay, they have a fixed decrease in oxygen demand. However, in patients who have vasospasm, in addition to the existing atherosclerosis, right, then it can be even more symptomatic. Okay, this usually occurs at the place where the plug is or downstream to the plug. Okay, and when vasospasm happens, it's usually due to damage in the blood vessel. Okay. Another form of angina would be the Prince metal angina. These patients, they do not have any atherosclerotic plaque, but they have vasospasm at the vessels. Okay, this is due to production in the reduced production of the natural vasodilators and exaggerated response to endogenous vasoconstrictors. So there's no plaque, but the body just have an increased response to the natural factors that cause vasoconstriction, and they cannot vasodilate that well. Okay, so this type of angina, they are not exactly the same as the coronary artery disease, chest pain due to the coronary artery disease. Okay, so all of you have gotten it right. So the answer is actually C. Okay, I also want to, so the other options, right, B and D, they are not, they are also, they are also the differentials of differential diagnosis of coronary artery disease. So a lot of times when the patients actually present to the hospital, they actually have, they complain of chest pain, and then sometimes they say that it's not, it is irrespective to the whether they are exercising or not. So sometimes it can be due to acid reflux, and because the esophagus, right, is actually in front of your heart, correct? So sometimes the patients have acid reflux. They may complain that it's actually epigastric pain. Okay, so when patient present with this chest pain, right, we need to rule out that it is due to acid reflux. Okay, and then D, right, a lot of times, sometimes they have this actually musculoskeletal pain. So sometimes they have exercised too much, and then they have damage or cause overuse of the muscle of the chest wall. It can also result in pain. So when patients present with chest pain, it's not all the time is due to the heart. Okay, we need to rule out other causes of chest pain or pain in the chest area. Okay. All right. Question 3. You ask Uncle Sam, what symptoms do you experience? You expect his answer to be A. Each time I have pain, I feel a sour breath in my mouth. Oh, I have been burping quite a fair bit. B. I had fever and runny nose 2 weeks ago. Then I started having this sharp stabbing chest pain in my chest. It's better when I lean forward, worse when I lie down. C, I've been doing intensive pull-ups. It's achy whenever I lift heavy things. And D, the pain comes when I climb the stairs. It is less, this pain on the left side of my chest. And sometimes the pain extends and radiates to my neck, and it goes away when I stop and rest. Okay, so now I'm going to toggle back into Kahoot. Okay, so for the previous question, in the lead, we have oopsie, DTSY. Good job. Okay, so let's go on to the next question, okay? So you ask Uncle Sam, what are his symptoms? All right. Okay, so most of you have answered D, the green square. Okay, good job. That is the correct answer. Okay, let's go back to the slides. Okay, so most of the time when the patient present, we have to take careful history because by taking a good history, right, we actually can uh, uh, determine the diagnosis actually 70 to 80% of the time. Okay, we should check with the patient how is the manifestation of the cardiovascular disease. So in this case, I was referring to the pain lah. Okay, so you have to ask the patient what type of pain it is, which we'll talk about it in the next slide. We'll also talk about ask the patient about risk factors, whether their family history, so their parents, whether they have young onset of coronary artery disease, or if they had passed away from heart attacks before or other coronary artery disease, whether they have history of dyslipidemia, high cholesterol, whether they had diabetes, whether they had hypertension, whether they are concurrently smoking, or whether they have other lifestyle factors. For example, they are drinkers, heavy drinkers. And just to note, smoking also, we have to check with them whether they are passive smokers. So sometimes their family members are the one who are smoking, but they themselves are not smokers. Okay, so this can help us ascertain the risk and how likely they are to be having some form of coronary artery obstruction. Okay, so this table that you see on the right side is actually taken from the ESC guideline, the European Society of Cardiology guidelines. Okay, is the type of chest pain can be classified into three groups. Typical angina means that they meet three of the following characteristics. And what are these characteristics? Is that they have constricting discomfort in the front chest or in the neck, jaw, shoulder, or arm. So sometimes they may say that it radiates. Okay, so the chest starts from the chest, and then there's this pulling sensation. Okay, that goes to the neck, to the jaw, and it is precipitated by physical exertion. That means, let's say, for example, they have to carry heavy things, whether they have to climb the stairs, they have to chase the bus. Okay, so if they have physical exertion and the chest pain comes on, is actually quite telltale of a typical angina. And let's say if they rest or they take nitrates and the chest pain goes away within 5 minutes, then this is very telltale of a typical angina. Okay, atypical angina means that they meet only two of the three characteristics. That means it may or may not be so classical lah. Okay, we will still need to investigate further. Non-angina chest pain means that they meet only one or none of these characteristics. Okay, so when the patient comes to you, we will ask the patient what type of chest pain that he or she has. We can use the PQRST mnemonic to help us conduct the patient interview. So for patients who have coronary artery disease, like we mentioned earlier, usually the precipitating factor, okay, P, the first P, is due to exertion, right? So brought about by exertion or exercise. So you can ask, what were you doing when the chest pain started? Okay, the second P is palliative measure. So what do you do to help is there anything that you did to help the pain go away, or is regardless of your action, the pain is still constant? Okay, then if it is due to CCS, right, then it is relieved by rest, or whether there is a use of a nitrate lah. Okay, quality of the pain, so whether it is squeezing, heavy, tightness. Okay, so these are the words that they can use. Sometimes they may say if it's stabbing, poking, then this type of pain is less likely to be due to stable angina lah. Okay, region usually is in the substernum, that means in the central of the chest. Okay, the sternum is the center bone, the center chest bone. Okay, so usually they can feel that the pain is below that. So you can ask the patient, can you point to me with one finger where the pain is? Or if they say they can't locate sometimes they may say that they cannot locate the pain lah. Okay, whether it radiates to the arm or to the jaw or to the neck. Okay, if it does, then it actually sounds like it's quite typical. Okay, severity, you can ask them on a scale of 5 or usually we ask them on a scale of 10. Okay, if they have a pain score of 5 and above, then it is quite telltale of CCS as well. And whether it is how long does it last, the temporal pattern, in other words, the timing lah. So does it last for a long time, like half a day, or does it go away in say 2-3 minutes or 1 or 2 minutes? Okay, so these are the questions that can help us ascertain what is the chest pain story. Okay, so I just want to briefly go through some of the diagnostic and prognostic testing. Why do I want to go through that? Because it will help you in your pre-reg days, what to look out for in the case notes. Because there might be a lot of tests and you might not know what it means. It will be quite overwhelming, but rest assured that this part of the content will not be tested in your exams, okay? So some things that you want to look out for in a patient who presents with chest pain, the doctors usually will 100% of the time, they will do a ECG, okay? So this ECG will tell us whether there is any change in the pattern of the patients from their normal ECG lah. So if there is a change, there's a change in the ECG, right, even at rest, then it's quite telltale that there is some form of ischemic heart disease. Okay, next, that would be the stress test and stress echogram. Okay, so in other words, they get these patients to actually undergo some stress. They can be running on a treadmill, that is the exercise stress test, or if some patients, they cannot, they say that they have osteoarthritis, they have like knee pain, or let's say they are an amputee, okay, then they cannot run on the treadmill. Some of the patients are very frail. Let's say if they are 80 years old, you don't expect them to run on a treadmill, right? Okay, so in those cases, we'll administer a physiologic stressor. Okay, these physiologic stressors can be dipyridamole or dobutamine. Okay, dipyridamole actually causes vasodilation. Okay, so it will dilate the healthy blood vessels more than the diseased blood vessels. Okay, and then this will cause the shunt of the blood flow away from the diseased portion of the heart. Next, this is dobutamine. Dobutamine is actually something that is like the opposite of beta blocker. Okay, your beta blockers will slow down the heart rate and reduce contractility. Dobutamine is the opposite. It's a beta agonist, so it increases the heart rate, increases the contractility. Okay, so it makes the heart work harder. Okay, so if the heart is made to work harder, okay, and the ECG, there is a change in the ECG when the patient is put to a stress, or where there's a change in the echogram, means that there could be some underlying coronary artery disease. Okay, so the echogram is like an ultrasound. For example, pregnant women, okay, they have this ultrasound probe where they put against the belly with some gel on the surface of the belly, and then they can image the fetus. So in the echogram, it actually uses the same technology, but the probe is placed against the chest wall, okay, or the side of or below the. So they'll move around lah, so, and it will actually help you image different parts of the heart. Okay, it can help us image how well the heart contracts at rest or under stress. Okay, so when that happens, when under stress, the heart cannot contract properly. It looks like the contractility, the ejection fraction. Ejection fraction is the amount of blood, the fraction of blood that is is ejected out of the left ventricle with every contraction. So if there's a drop in the LV under stress, if there's a drop in the EF under stress, then it's also quite telltale that there is some form of underlying coronary artery disease. Okay. Okay. I know this is quite a lot to go through, as in to understand, but if you have any questions, you can actually stop me in between to clarify, okay? Okay, next is myocardial perfusion imaging. What happens in this test is that the patient actually receives an IV administration of a radioactive tracer, and the radioactive tracer, right, will be distributed to the heart muscles. The uptake of the tracer, right, is proportional to the coronary blood flow. That means if the heart vessels, right, are diseased, then the take-up rate of the blood as well as the blood that has the radioactive tracer, right, is reduced. And they will put the patient under a detector, okay? And then they can see under the detector how much, what's the distribution of the tracer. Okay, so they do this at rest and during rest, and then they will see whether there's a difference in the distribution. Okay, so this is the MPI, myocardial perfusion imaging, or sometimes they may also call it the MIBI test. Okay. Okay, the next one is cardiac MRI. So what they do in cardiac MRI is that they ask the patient to lie in the MRI machine, and from the MRI machine, they can actually see it more clearly in terms of to stage the disease lah. So sometimes in addition to the ultrasound, they may, if the ultrasound cannot show certain images as clearly as they had wanted it to be, they will they will actually let the patient do cardiac MRI. Okay, cardiac MRI is actually very clear, and they can see the morphology, like the layering of the heart muscle, better than the ultrasound. Okay, they can also do a coronary calcium scoring using the CT scan. That means they actually ask the patient to lie in a CT machine. Okay, and then they will calculate the coronary calcium score. So the higher the calcium score means that the chances of coronary artery disease is high. Okay, but having said that, as with normal aging, right, our vessels will also be calcified. So sometimes if the patient is very elderly, if they are, say, 65 years old and above, so there might be some natural calcification that is not due to atherosclerosis. So in those patients, then the calcium scoring will not be that accurate. Okay, then CT angiography means that they inject a little bit of dye, and then the dye will light up, will actually flow to the coronary vessels, and then they actually use the CT machine to shine some X-ray, is similar to X-ray on the heart, to see the distribution of the dye in the vessels. So if there is a coronary obstruction, right, then the amount of dye that is distributed to the diseased vessel will look like it's diminished, or it will be narrowed. Okay. Okay, last but not least, coronary angiogram or angiography, okay, is the gold standard of diagnosis. So what happens in the angiogram, right, is that they will inject a dye, and this dye is also known as the contrast medium, okay, will actually be distributed to the body, into the heart vessel. And this is usually done, injected into the arterial access. That means, so usually when you go for blood test, right, they take from the veins, but in this case, they will need an arterial access. So this is, it is considered rather invasive, because the risk that the pressure in the arteries is high, and the risk of bleeding with arterial excess is a lot higher compared to venous excess. But in order to do coronary angiography, right, you will need the arterial excess to actually to do it, to visualize lah. So what they do is that they will put in a probe to usually from the arm or from the groin to somewhere that is near the heart vessel. And then when the probe is there, they will inject the dye. And when the dye is flowing through the vessels, they will take images. It's also like X-ray, and visualize the flow of the blood. So sometimes if it's like similar to the CT angiography, if there is a narrowing, right, then we know that there's obstruction. Okay, so while this is the gold standard, why don't we give it to everybody? Because it involves certain risks. First, there's a risk of bleeding, okay, because it's an invasive diagnostic procedure, and it involves the use of contrast medium, and this contrast medium, right, can increase the risk of kidney injury or nephropathy. Okay, so in patients who already have baseline kidney impairment, for example, they have kidney disease from long-standing diabetes, for example, then unless it's totally necessary, we probably would try to avoid the use of contrast in those patients. Okay, so whether to use coronary angiography or not, right, is risk versus benefit, and it has to be discussed with the patient in detail. Okay, so far? If okay, can I see whether if there is some thumbs up or something like that? Okay, so if everybody is okay, then we will move on. Okay, so some of the basic biochemistry testing, right? That means we will need to do some basic bloods for all patients who come in with chest pain, and we will be looking at things like full blood count, okay? Because we want to look at the hemoglobin, okay? Mainly the hemoglobin as well as platelet. So hemoglobin is the entity that carries the oxygen, right? Okay, and also to look at the platelet. So this will help us ascertain if the patient is at risk of bleeding or not. So if the hemoglobin is low, platelet is low, then the risk of bleeding is high. Then it will help to give us some sense of risk stratification, whether patient should go for angiogram or not. Okay, we'll also look at the renal function. So we'll look at the creatinine. Okay, it's called the renal panel. So we look at the creatinine to see how is the kidneys doing. Lipid profile, this will help us to ascertain what is the patient's risk. Okay, if the patient has diabetes, it's also recommended to screen for diabetes. So most of the time when patients present with chest pain, right, we'll do FBC, full blood count, renal panel, lipid panel, we'll do a HbA1c and fasting plasma glucose, and at the same time we'll also look at the thyroid function. So this is the 1, 2, 3, 4, 5 sets of tests that is commonly done when patients present with chest pain. Why do we want to look at the thyroid function? Because if the patient is hyperthyroid, okay, then the heart will always be pumping very fast. Okay, so thyroid, what it does is that it regulates the metabolism in the body. Okay, so if the thyroid function is deranged, if there's too much thyroid hormone, right, the heart pumps very fast, very hard. Okay, it can increase the chance of heart cardiomyopathy, or that means damage to the heart muscle. Okay. So the goals of therapy in patients who have chronic coronary syndrome is to reduce the chest, the pain, the chest pain. Angina means chest pain. Okay, angina symptoms, and also exercise-induced ischemia. At the same time of controlling the symptoms, we also want to prevent future cardiovascular events as well as death. So these cardiovascular events, we are actually referring to myocardial infarction. In other words, that could be our acute coronary syndrome. Okay, like we mentioned way ahead in the slides, and also to reduce the incidence of acute thrombotic event and development of ventricular dysfunction. What it means is that, let's say if I have heart attack, right, a few times, okay, each time the heart attack happens, okay, some of the heart muscle die, okay, infarction means death lah, okay, myo means muscle, right, heart muscle, death, okay, myocardial infarction. So each time I have an MI and some parts of the muscle die, and over time, right, okay, this can cause the heart function to reduce. Okay, that's how patients develop heart failure. Like you have gone, it's similar to, it is the heart failure, which is the one that you learn in your heart failure lecture. Okay, so we want to prevent that from happening. Okay, so back to our Uncle Sam. So Uncle Sam said that his symptoms would be D. Okay, that would be that was what most of you have gotten correct lah. Okay, so the first one, A, right, is due to acid reflux. Okay, because each time he has the pain, he feels that there's sour breath. In other words, that when he burps and or there's reflux, right, some of the gastric acid actually goes back to the mouth. Okay, so if they have chest pain and they have this sour breath in their mouth, so it could be due to gastric reflux, less likely due to the heart itself. Okay, B, right, he says that he had fever and runny nose 2 weeks ago. It does sound like an infection, right? Then after that, he had this stabbing chest pain. So this could be due to myocarditis or pericarditis. So I'm sure you have heard about the myocarditis that is due to the COVID vaccination, the mRNA vaccination. So this is what it means. That means there's inflammation of the heart muscles itself, or due or the inflammation of the this lining outside the heart itself. Okay, so when they it's very telltale when they say that it's better when they lean forward and worse when they lie down. Okay, so when that happens, then and plus there's evidence of infection, especially viral infection, right? Then we might think that this is due to myocarditis or pericarditis. Okay, so that is not a heart attack. Okay, so C, he said that he has been doing intensive pull-ups, and when he carry heavy things, it's achy. So it sounds like it's musculoskeletal pain. So again, this is not due to the chest pain, not due to coronary artery disease, not stable, not angina. Okay. Right, okay, question 4. Uncle Sam is a non-smoker. He is a social drinker. His past medical history is significant for hypertension, diabetes, and hyperlipidemia. Today, you take his blood pressure, okay, and it is 128/77. His other labs are as follows. His creatinine is 67, potassium 3.9, HbA1c 7.5. So HbA1c is a measure of how well the sugar control is over the past 3 months. Okay, 7.5 is a little bit on the high side. Okay, so 7, most people, we want it to be less than 7. The goal is according to the patient's age as well as the patient's premorbids, how well they are in the community, whether they can dress themselves, whether they can go and buy their own food, whether they can take care of themselves, for example. Okay, so and also their life expectancy. So 7.5 for Uncle Sam is a little bit on the high side. His LDL is 4.3, his triglycerides is 0.8, his weight is 68, and his BMI is 25. So can you tell me what are his risk factors for cardiovascular disease? Okay, is it A, hypertension, B, diabetes, C, hyperlipidemia, D, obesity? So these, right, are actually, this question would be a multi-answer question. Okay, so I'm going to toggle over to the Kahoot. Okay, oopsie, DTSY is still the top. Good job. Okay, next question. Multi-select. Okay. Right. Okay. So most people have selected diabetes, and the second most common is hyperlipidemia. Okay. Quite a good number of you have chosen hypertension and obesity. Okay. Let's look at the content. Okay. 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 Let me see if I have. Okay, so I'll be back to that later. Okay, so treatment algorithm. After we have identified that this patient has stable ischemic heart disease, or we have identified this patient has stable angina or chronic coronary syndrome, whichever you call it. Okay, after we have obtained a diagnosis, we need to there are two arms that needs to be done concurrently. We have to modify the risk factors, and we also have to manage the angina. That means we manage the symptoms. So we'll come to this portion later on. Let's talk about the risk factor modification. Okay, so the patient needs to be needs to undergo lifestyle modification. I'm sure you have heard this many times. So the patient needs to go for diet, exercise, weight reduction, and smoking cessation. Okay, the patient should receive the annual influenza vaccine, and we should also manage the comorbidities. So if the patient has hypertension, we treat the hypertension, make sure it's at goal. If the patient has diabetes, we make sure that the HbA1c is controlled. And at the same time, we start the patient on statins. We also want to start the patient on some antiplatelet. Okay, we'll go through the details later. And we also want to start ACE inhibitor if they have any of these comorbidities. Okay, so this part of the arm, right, is to actually prevent further how should I say, events, cardiovascular events. Okay. So smoking cessation, so as pharmacists, actually, we have a big role to play in smoking cessation, because all your cardio patients that come in, right, a good portion of them, I would say more than 50% of them, a lot of times they are smokers. Okay, so we will teach them that they will need to encourage them to quit smoking. Okay, they should also be put on, they should also change their diet or make sure it's a healthy diet. So what is a healthy diet? Things that is high in fruits, vegetables, whole grains. Okay, limit saturated fat and limit alcohol. Okay, so if you tell the patient, right, what is limit the fat to less than 10% or limit alcohol to less than 100 grams per week, is usually very hard. They probably won't know what this means. I also don't know what this means, but generally, right, we'll just tell the patient to avoid animal fats. Okay, animal fats would be, for example, bak chor mee, they always put the pork lard, right? I like it a lot. Okay, so that one have to cut down or don't take anymore. Okay, or let's say if it is like kambing soup kambing, okay, the lamb soup, right? Okay, you have ask them to reduce, as in avoid or take less of it, because that has a lot of fats. Okay, so generally avoid animal fats that would help to reduce the saturated fat intake. So increase vegetables and fruits, whole grains. So whole grains would be, let's say, your brown rice, your multi-grain bread, okay, instead of the white bread, instead of white rice, okay. Physical exercise, physical activity, we encourage 30 to 60 minutes of moderate physical activity on most days. So it is recommended at least 150 minutes a week. So if the patient can do 30 minutes for 5 days, Mondays to Fridays, then that is 150 minutes. Okay. If it's lower intensity, it is then they will have to do a longer duration. Okay. But again, it is difficult it is difficult to explain to the patient that you need to exercise, put aside 30 minutes every day. Most of the time they won't do it. Okay, so we can actually encourage the patients to, for example, instead of taking the bus, okay, they can actually walk the bus stop, like 2 or 3 bus stops to get home, because by walking further distance, it increases the heart rate, okay, and that would be considered some form of exercise. So even irregular activity is beneficial. So some exercise is better than no exercise. Okay, so we should try to get our patient moving all the time. Healthy weight, they should have a healthy weight of less than 25 kg per meter square. And this is recommended by limiting the dietary intake and increase physical activity. So for this, right, this 25 kg per meter square is actually based on the Caucasian statistics. So in Asian statistics, right, we want this number to be less than 23. Okay, so less than 23 kg per meter square for Asians is considered a healthy weight. Okay, then also take the medications as prescribed, and also sexual activity is okay. Then and patients should go for vaccination. Okay, as for smoking, right, I will not go into the details, but we have to explain to the patient to quit smoking, and these are the 5 A's lah. We ask the patient whether they are smoking or not. Yes, no. If they are smoking, then you advise them to quit. But if you tell them to quit, I'm sure they already know the harms of quitting. We have to assess whether patients are ready to quit. Okay, if they are not ready to quit, whatever you do, right, they also don't want to quit. Okay, the readiness should come from within the patient lah. Okay, then if they are interested, if they are ready, then you assist with smoking cessation. That could be that can be counseling, can be if they have withdrawal symptoms, you can give them nicotine replacement therapy. Okay, that's how we assist. Okay, then subsequently we'll arrange for follow-up to see how they are doing with the progress. Instead of in terms of healthy diet, okay, similar as before, we mentioned that we want to increase fruits and vegetables, increase fiber intake. Okay, moderate consumption of nuts is actually good. Take fish instead of the other forms of meat, like red meats. Okay, when they do take meat, okay, limit to lean meat. So in like chicken breast is considered lean meat compared to, for example, the chicken thigh and chicken drumstick, right? They are not so lean. Okay, saturated fat should be low. A small amount of okay, so try not to take processed food, and then even if they are taking unsaturated fats, right, make sure that it is not trans fat lah. Because trans fat, right, actually is actually worse. It actually causes the worse cardiovascular effects, okay, compared to trans-free fats. Okay, so if you go and buy margarine, you will see on the labels, right, they will tell you whether that is trans fat free or not. Limit the salt intake. If alcohol is consumed, limit alcohol, and avoid energy dense food, for example, sugar sweetened soft drinks. So very standard lah, so healthy characteristics of the diet. Okay, so for Uncle Sam, right, his cardiovascular risk factors is actually all of them. He has hypertension, he has DM, he has hyperlipidemia, and he also has a weight that is this is the European weight. Okay, so he's an Asian, right, Uncle Sam? He's an Asian man, so it should be less than 23. Okay, so obesity is also one of the risk factors. Okay, so my apologies. So let's go on to the next slide. Okay, so question 5. Uncle Sam's medication before he saw the cardiologist are as follows. Metformin is diabetes medication, lovastatin, and amlodipine. what are the changes that you'll make today to optimize his risk factors? Okay, so right, for the purpose of this question, I've changed the HbA1c here to 6.9 because I understand that you have not undergone your diabetes lecture. So at this point of time, Uncle Sam's HbA1c, right, is 6.9. Okay, what changes would you make to optimize his risk factors? Would you A, increase metformin, B, change lovastatin to atorvastatin, C, increase amlodipine, or D, add glargine? Glargine is actually a type of insulin. Okay, so insulin glargine to his regimen now. Huh? So will you add that? Okay, I'm going to toggle over to Kahoot. Okay, I Love Cardiology is leading right now. Next question. Okay, so most of you have answered to change lovastatin to atorvastatin. Yes, good. Okay, so let's go back to the slides. So how do we manage the comorbidities? For hypertension, we suggest a goal of less than 130. That is based on the ACC-AHA, the American guidelines. The European guidelines actually recommend 120 to 130, as opposed to patients, and for patients who are older, right, they are more lenient. Okay, 130 to 140. Reason being that because some patients, if they are higher, they are older, right, then they are more likely to have postural hypotension, it can cause the adverse effects of the medication. They may also have giddiness and increase the risk of fall. So therefore, sometimes it can be more lenient. But having said that, there's no hard and fast rule. Always assess your patient, whether the patient can tolerate the symptoms or the medications or not. Okay, the choice of the agents are guided by the comorbidities or other compelling indications. For example, if the patient has symptomatic coronary CCS, or patient has recent MI, DM, or heart failure, it might change the choice. For example, if I have symptomatic CCS, I'll be more likely to use beta blocker, which I will go through later. If patient has recent MI, I'll also be more likely to use beta blockers. If patient has DM, then I'm more likely to choose an ACE inhibitors or ARB because it has kidney protective function effects. And if the patient has heart failure, then I'm more likely to choose the ACE inhibitors, correct? Because that is beneficial for your heart failure patients that you have learned through the heart failure lecture. Okay, so what is written here is from the guidelines, and it is the same as what I've discussed earlier. Okay, so hypertension, patients with recent MI, beta blockers, RAS blockers. RAS blockers would be your ACE inhibitors, ARB, but beta blockers first. Okay, beta blockers first, then your RAS. Then a patient who have symptomatic angina, again, then beta blockers and CCB calcium channel blockers. So again, how we choose the two of them, later we'll discuss in the subsequent slides. Combination of ACE and ARB, not recommended, okay? Now, there is no indication that should use both ACE inhibitors and ARB, okay? As for diabetes, right, it's important to control diabetes because patients who have diabetes and coronary artery disease, they are very high risk, okay? Therefore, we need to be stricter on the control. The BP target for this group of patients is usually stricter as well, 120 to 130 systolic. But having said that, this is again according to tailored according to the patient's specific patients. So I think this is a typo, it should be 75, okay? So the target LDL, right, is less than 1.8, okay? There's a star here, okay? This is based on the European guidelines, okay, or at least 50% reduction from baseline. Okay, you will learn that this. I'm sure from your hyperlipidemia lecture, you have known that there are several targets and different how should I say, guidelines actually recommend different targets or different intent, as in slightly different approach. But nonetheless, don't worry, because specifically if in the exams, right, we won't be asking controversial things. Okay, it'll be very obvious what the patient's LDL is at that time when you need to administer the treatment. Okay. Then the HbA1c target should be less than 7%. So again, this is the control of the blood glucose in the past 3 months. For most patients, it should be less than 7%. Okay, of course, dependent on the patient's premorbids. And remember that metformin is always the first choice. Okay, metformin is always the first choice for diabetes unless contraindicated. So metformin is is an oral tablet and is usually contraindicated if the patient has very poor renal function. Okay, because metformin, when given if it's not cleared from the body, right, it can cause lactic acidosis. Okay, but don't be too worried about this because we won't be going. This won't be tested in your exams. Okay, because diabetes is not covered yet. Okay, so risk factor modification for diabetes and CAD patient, okay, needs to be tighter lah, okay. And then ACE inhibitor is recommended for patients with diabetes for prevention of events and also to protect the kidneys. They may also use SGLT2 inhibitors if they are diabetic, because this group of drugs, right, is shown to have cardioprotective effects. Again, don't be too worried about this. This will not come out for your exam, okay? And also things like liraglutide, the glucagon-like peptide receptor, liraglutide, and we don't really have this lah, okay? So most of the time it's liraglutide, okay? This is also, this can be used, okay? But this is an injectable, so it's not so easy to use lah. So most of the time patients are started on metformin, then they may add on the SGLT2 inhibitors. Okay, that means all the gliflozins. Okay, don't be too worried about this. This is for facilitation of your next time if you want to use these notes to help you in pre-reg, right? Then you can refer back. But having said that, by that time the guidelines might have changed lah. Okay. Okay, this lipidemia. Okay, patients with established CAD, they are considered very high risk. Therefore, lipid-lowering therapy must be considered regardless of baseline LDL. So now you see that this target LDL is 1.4, okay, because it's taken from a different guideline. Okay, so don't have to be very worried about this. Just know that patients who have coronary artery disease, right, we are going to be very aggressive with the lipid control. Okay, so statins are recommended for all patients. So even if their LDL is 2 or 2.3, okay, they are considered normal for general population. But for CCS patients, we will just start, okay, statins. If the patient's goal is not achieved, then we might consider adding ezetimibe. I'm sure you have learned this in school, from Dr. Tan's lecture. And then those who are at super high risk, okay, and they cannot achieve their dose, their goal, right, with statin and ezetimibe, then they can use a PCSK9 inhibitor. Okay, that one is a very expensive drug lah, so it's not as first line as the statins and ezetimibe. Okay, so I'm sure Dr. Tan has gone through this before. High intensity is 40 to is usually we try to do 80 if possible. Okay, in practice, 40 to 80 is considered high intensity, but in Asians, right? Usually we start with 40 first, okay? If really cannot, then we increase to 80. Then for rosuvastatin, again, similarly, we'll start with 20 first, okay? But in America, right, most of the time they will start with atorvastatin 80 right away, okay? Because Asians, they are worried that there are more adverse effects with Asians. That's why we start on the lower end of 40, okay? And this is just a reference for you to indicate what is considered the equivalent dose of the statins. Okay, so back to Uncle Sam's medication. So what I will do today is I will change lovastatin to atorvastatin. Okay, why? Because actually his LDL is high, 4.3, right? Is high, and he's on a low intensity statin of lovastatin. Okay, HbA1c, my apologies, I forgot to change this. It should be 6.9. So if it's 6.9 means that he's at goal. Okay, less than 7, right? So we don't have to increase metformin. We are not going to add glargine. Are we going to increase amlodipine? Not really, because his blood pressure is not too bad. It's less than 130. Okay. Okay, question 6. We finally see a different face. This is Mr. PLM. He's a 69-year-old security officer. He presents to the polyclinic with chest pain on exertion. He was referred to the cardiologist. After extensive workup, he was given a diagnosis of stable angina and he opted for medical therapy. His it should be TTE, transthoracic echogram, my bad. So this is not transesophageal, should be transthoracic echogram, which is the echo lah, that means they put a probe on the chest to visualize how well the heart muscle pump. Okay, the EF is 55%, and his past medical history is significant for hypertension and diabetes. His labs are as follows. He has creatinine of 89, potassium of 4.2, HB of 14, which is good. Okay, platelet of 340, which is good. Okay, LDL 4.5. I'm sure by now you can see what is the trend, what type of LDL levels that will give you, that will show in the exams lah, at least in my part of the exam. Okay, and the triglyceride is 1.2. Okay, the urinary albumin to creatinine ratio is 70 milligram per gram, which means that he has albumin in his urine. Okay, HbA1c 7.5%, not too good. Blood pressure 159/93. Okay, you decide whether this is high or low. Heart rate is 80. Okay. His current medications are as follows. He's taking metformin 850 3 times a day. He's taking amlodipine 2.5 every morning and atorvastatin 80 milligrams at night. So before you want to start him or adjust his medication, what is the number one question that you must ask him? Okay, because you see that his parameters are not very well controlled, right? Okay, so you want to ask him something about his therapy before you adjust the medications. So I'm going to toggle to Kahoot. Okay, well done. I love cardiology. Okay, this is an open-ended question, so you can just key in your answer. All right, okay. Let's see. whether we can look at some answers. Very good. Okay, I am very proud of all of you because most of you have answered correctly. So we want to know whether the patient has been adherent to his therapy. Okay, do you forget to take the medications? Are you adherent to your medications? Do you have difficulties? That's a good way to ask as well. Okay, are you taking the medication as prescribed? That's fine. Okay, good, very good. This is what I was looking for. I want to know whether the patient is compliant, because you see that he's not very his therapy is not very his parameters are not very well controlled. Okay, so right. So the next question is, how would you optimize his cholesterol control? Are you supposed to? Will you add ezetimibe? Will you change atorvastatin to simvastatin? Will you increase atorvastatin to 100? Will you start evolocumab? The evolocumab is the PCSK9 inhibitor lah. Okay, so would you start? So this dose is definitely correct. Okay, but the question is whether you are supposed to start or not. Okay, so I'm going back to Kahoot now. Okay, good job on this question. I'm very proud of all of you. Okay, good job. Okay, most of you have chosen to add ezetimibe. That is the correct answer. Okay, why do we not change atorvastatin to simvastatin? Is because atorvastatin is high intensity, right? Then simvastatin is low, moderate intensity. So we do not reduce the intensity of the statin, especially if it's not well controlled. Okay. Do we increase atorvastatin to 100? No, we don't do that because the maximum dose is 80. Okay, we will not give anything more than 80. Okay, then do we start evolocumab now? No, not yet, because we want to optimize first. Optimize using ezetimibe. Okay, then we will. If that fails, then we can consider starting evolocumab. Okay, good. Okay, yeah, I love cardiology is still leading. Good job. Okay, so how would you optimize his medications today? Will you start aspirin? This dose is definitely correct, 100 mg morning. True or false? Okay, it's a true or false question. Okay, true, yes. So most of you have answered true, yes, because I will also start the patient on aspirin. So let's go back to the slides. Okay, so for antiplatelet therapy, right, for all patients who have any form of coronary artery disease, okay, we will want to give them antiplatelet. So antiplatelet could be aspirin, clopidogrel. Most of the time is these two types lah. Okay, so the rationale is because platelet activation and aggregation is the driver for symptomatic coronary thrombosis. So let's say if the patients have a rupture in the fatty plaque, right, then the platelets will be activated and then it will clump together. So the anti-platelet therapy will help to prevent, stop this process, and therefore it reduce the risk, subsequent risk lah. So we can give aspirin 75 to 100 milligrams a day, but in Singapore, the dose that the tablets that we use, right, is 100. In America, sometimes if you read the guidelines, they might say 81 milligram, which is very weird lah, okay? But in Singapore, we use 100. Okay, this acts via irreversible inhibition of the COX-1 enzyme and also blocks the thromboxane production. Okay, so that's how aspirin works. So if the patient they cannot tolerate aspirin, okay, for example, they are, if they are allergic to aspirin, if they take aspirin, they have anaphylaxis, okay, or if they take any other forms of NSAIDs, because aspirin is a type of NSAID, right? If they take other form of NSAIDs and then they have anaphylaxis, okay, then we will change them, instead of aspirin, we'll give them clopidogrel. Okay, clopidogrel is 75 milligram once a day. It works via a different pathway, mechanism of action, okay, different mechanism of action from aspirin. Therefore, they can be used in the event the patient have aspirin allergy lah. Okay, they block the P2Y12 receptor, which also plays a part in platelet activation, and therefore it prevents the formation of thrombus. Okay, but the problem with clopidogrel, right, is that it requires conversion into active metabolite by this enzyme called the CYP2C19 enzyme. In other words, right, if this enzyme doesn't work, okay, then the patient will have reduced metabolism. That means they do not have they probably may not have enough activity from the clopidogrel. Okay, then patients who do not have sufficient activity from the active metabolite, right, means that they do not block the antiplatelets that well. They do not block the platelet activation that well. So this is a shortcoming. Okay, therefore, in patients who are on clopidogrel, right, we'll have to make sure that CYP2C19, if there's any drugs that inhibit CYP2C19, right, then we have to we may need to adjust the therapy if necessary, or we may need to be more alert. Not all the time we'll adjust the therapy, okay, but we will need to pay attention to it. Okay, so this is from the guidelines. We give aspirin if the patient, if patients have cardiovascular events, and or rather to prevent cardiovascular events, clopidogrel can be an alternative. Okay, I think these two are the important things that you need to know. Okay. Okay, so for Mr. PLM, so I will start aspirin in this case, okay, because he has a coronary artery disease, because he has a stable angina, right? Okay, so the next question is whether you will start lisinopril. Remember, this patient, he has hypertension, he has diabetes, his blood pressure today is 150 something, and he has protein in his urine. Okay, so whether you will start lisinopril today, okay, I'm going to toggle over to Kahoot. Okay, good job. I love cardiology. You're still top on the list. Okay, in the interest of time, I think most of you have answered. Okay, good. Okay, so yes, so most of you have answered it correctly. Yes, I will start lisinopril for this patient. Okay, let's go back to the slides. Okay, so ACE inhibitor should be started and continued for all patients who have EF of 40% or less, those who have hypertension, those who have diabetes, and those who have stable kidney disease. Okay, why? Because lisinopril, right, or ACE inhibitor or ARB, they have protective function of the heart, okay, in reduced EF, and it also prevents further deterioration of, it controls blood pressure. It also prevents deterioration in terms of the kidney function in patients who have diabetes and those who have stable chronic kidney disease. Okay, ACE inhibitors is acceptable for all patients with cardiac or other vascular disease. ARB can be used if the patient has ACE inhibitor, for example, if they have ACE inhibitor intolerance, for example, those who have severe dry cough that affects their day-to-day activity. And contraindication includes hypotension, those who are pregnant, those who have bilateral renal artery stenosis. Okay. Okay, so yes, I will start lisinopril. Okay, so next we'll go on to the anti-angina therapy. So if you flip back to your notes, right, you have at the beginning of this section, we actually look at the the two arms, right? One arm will look at the disease prevention. Now we are going to look at the management of the symptoms. The goals of the treatment is that the optimal treatment should actually control symptoms, prevent cardiac events, okay, helps the patient with adherence and minimize the adverse effects. There is no universal definition of an optimal treatment for CCS. It must be adapted to the patient's characteristics and preferences. So it really depends on how you individualize the therapy for the patient. Okay, so you need to consider whether patient has any forms of comorbidities like diabetes, or the patient has hypertension. Yeah, so a lot of things to consider. Okay. So our next question is whether we want to start the patient on bisoprolol. Bisoprolol is a beta blocker, right? So true or false? The dose is definitely correct, 2.5. So true or false? Oops. Okay, so let's go back to Kahoot. Okay, good job. Okay, so most of you said that you will start a beta blocker. Yes, I will start a beta blocker as well. So the answer is true. Why? Come, let's have a look. Okay, so right, patients who have this is the treatment algorithm for patients who have symptomatic angina. Okay, so standard therapy, you usually start the patient on a beta blocker or CCB. The rationale is if we want to, so beta blocker will help to reduce the heart rate. Okay, so later on we'll discuss how it actually, what is the rationale. Okay, so if the heart rate is high, then we'll start a non-dihydropyridine. If the patient's heart rate is normal, okay, or not super elevated, right, then we can start a calcium channel blocker. But nonetheless, the first line, right, is either to give beta blocker or give a CCB. Second line it depends on how the response is, then we might add on if the patient is started on beta blocker, then we might start a calcium channel blocker. Or if the patient's heart rate is too low, then we may switch to a long-acting nitrate. LNA is a long-acting nitrate. Okay, or we can use ivermectin. Okay, or we can switch over to ivermectin. Okay, depends on how the patient's response is. Third step, we add another drug. Okay, and then fourth step, we can start ranolazine or trimetazidine. We'll talk about this later. Okay, so this is taken from the guideline. Okay, short-acting nitrates recommended for immediate relief. So that is nitroglycerin or GTN. I will go through that later. First-line treatment is always with beta blocker or CCB to control heart rate and symptoms. And if angina symptoms are not controlled, okay, then you can use a combination of them. The initial first treatment with a beta blocker or dihydropyridine should be considered. Okay, so this is the guidelines. The guidelines very loose one. Okay, then the long-acting nitrates, right, should be considered second line. Okay, and when long-acting nitrates are given, they will go through this in detail. And this is the second line treatment, the second or third line treatment, ivermectin and trimetazidine or ranolazine. And patients with low heart rate, the first go-to is ranolazine or trimethazine, but this one is very, we don't usually give it as first line, okay? Okay, yeah. So for beta blockers, the rationale of giving beta blockers is that we want to reduce the heart rate because remember when our heart beat very fast, then it requires a lot of oxygen, right? Okay, so we want to reduce the heart rate, that will improve symptoms. We want to reduce the myocardial contractility as well as the intramyocardial wall tension. Again, these will also reduce the oxygen demand, okay? So beta blockers is able to mitigate all the oxygen demand using via this mechanism. So in patients whose heart rate is still high, right? For example, in our patient here, Mr. PLM, his heart rate is 80. So we can still add a beta blocker because the target heart rate is 55 to 60. This is at rest. So at rest, his heart rate is 80. So we can add beta blocker to titrate to a target of 55 to 60. Okay, whether they are beta-1 selective or not, it actually does not affect whether it's efficacious or not. So you need to consider whether patient's blood pressure at that time is high or low, whether patient has asthma. Okay, that will help us determine what type of beta blockers to choose. So adverse effects includes fatigue, depression, bradycardia, heart block, bronchospasm, peripheral vasoconstriction, postural hypotension, impotence, and masking of hypoglycemic symptoms. Okay, so for this portion, you will it is actually important in real life, but we will not go through this now because you have not gone through the diabetes lecture, okay? But otherwise, patients, a lot of times they complain of fatigue, okay? Contraindication are those who have heart block, okay, and those who have asthma, especially if they are uncontrolled asthma. This is very important, yeah? Okay, and those who have critical limb ischemia, hypotension, those who have heart failure with unstable fluid status, for example, they are in fluid overload right now, you do not want to start them on a beta blocker while they are in exacerbation, okay? And those who have DM and frequent episodes of hypoglycemia, because that will mask the hypoglycemia, okay? So if the patient has COPD or the patient has, for example, asthma, not only COPD, asthma, those who have DM, those who have peripheral artery disease, and those who have this, sexual dysfunction and dyslipidemia, we want to choose beta-1 selective, okay, because they are specific to the heart. If they also affect the beta-2, then they will affect the COPD and asthma patients. If they also have peripheral symptoms, peripheral effect, then it will affect those who have the peripheral artery disease, and it will also mask the DM, okay? But do note that all agents lose their selectivity at high doses. So even though they, in theory, they say they are beta-1 selective, but if you give them at super high doses, for example, bisoprolol 20 milligrams, okay, then they will lose their selectivity. Okay, if we happen to need to discontinue therapy, then we should taper it slowly because during the therapy, right, the receptors becomes upregulated. So when you suddenly take out the medication, right, then there's a lot of receptors around, right? And then these receptors will cause catecholamine stimulation. That means your natural beta agonist in the body, okay, will bind to all these receptors, and this will cause a increase in oxygen demand, and it can also cause induced ischemia or even a myocardial infarction. All right. Okay, so this is a comparison chart of the selectivity and whether they are how lipophilic they are and what's the usual dose. Okay, the ones that have underlined are those that are commonly used in practice. Okay, so do pay special attention to these three lah. Okay, atenolol is beta-1 selective, so is bisoprolol, but bisoprolol can be used in your heart failure patients. Atenolol cannot. Carvedilol can be used in heart failure patients, but it is non-selective. Okay, so it can be useful in patients who have uncontrolled hypertension or with concurrent heart failure. Okay, and you want to use one agent to control both plus the stable angina, then you can use carvedilol. Okay, but let's say if they have uncontrolled asthma, uncontrolled COPD, then carvedilol would not be a good choice because it's non-selective. Okay, it has beta-2 activity in the lungs. Okay, it can cause bronchospasm. All right. Okay, so you need to choose the right agent for your patient. Consider the comorbidities. Okay, if patient has heart failure, carvedilol, biso, they are fine. Okay, if they have AF, you can use sotalol. Okay, I'm sure you have that covered in your AF lecture. Okay, if they have CKD or unstable renal function, we try to avoid atenolol because it can accumulate. Patients who have obstructive lung disease, poorly controlled asthma, okay, then you want to use the beta-1 selective agents. And if they are lipophilic, then it can cause more CNS side effects like depression, but cause them to be more drowsy. All right. Okay, so that's why for Mr. PLM, we will start bisoprolol, okay, because his heart rate is 80, okay, and his blood pressure is 150 something, right? So there's no issue with dropping the blood pressure further. So it is safe and it is logical to start him on bisoprolol. Okay, the next question is whether we'll increase amlodipine to 5 milligrams every morning, because right now he's on 2.5, right? So I want to give you a hint here. So now, so far what we have done is that we have started him on aspirin. Okay, same story, yeah. And then we have started him on lisinopril, and then we are also going to start him on bisoprolol. So now the next question is whether you want to increase amlodipine, true or false? Okay, I love cardiology is still leading. All right. Okay. So most of you say that you will not start increase the amlodipine. Correct. That is my answer as well. Okay. K, number 1 now. Good job. Okay. So what is the place in therapy for calcium channel blockers? The reason why we want to use calcium channel blockers is that it reduces oxygen demand. Why? Because it causes an increase in supply by inducing coronary vasodilation. Your calcium channel blockers work by vasodilation, right? So it will also cause the coronaries to vasodilate, and that will prevent and it also prevent vasospasm. Remember the patients who has vasospastic angina, okay, or Prince method angina, okay, your calcium channel blockers have this effect lah, so it can control vasospasm. The MOA is the same as with how you actually control blood pressure, okay. I will not go into the details of it. And remember that short-acting dihydropyridines, okay, DHP, CCB should be avoided as they cause reflex tachycardia. Okay, therefore, in practice, right, in the market there is nifedipine long-acting, nifedipine LA. There's no more nifedipine short-acting tablets in Singapore. I can't say for other countries, okay, but we do not use short-acting dihydropyridines, okay, because it can cause reflex tachycardia. That means we vasodilate, and then your heart thinks that, how come my blood pressure suddenly slow, right? Then they will increase the heart rate, okay, and then to compensate for the drop in blood pressure. And when that happens, it can actually make things worse, can actually make it worse for the patient's angina symptoms. Okay, non-dihydropyridines, which means is your diltiazem and verapamil, they reduce the heart rate and contractility through the blockade of myocardial calcium channels. Okay, this is the comparison. Oh, I forgot a point here. So nifedipine, right, compared to amlodipine, okay, nifedipine has produces more impairment on the LV function. So sometimes in practice, when you see a patient who has very reduced ejection fraction, for example, ejection fraction of 15 or 20%, okay, then they will try to switch the patient out of nifedipine and give them amlodipine instead for blood pressure control if needed lah. Okay, so this is the comparison of the drugs. Okay, the hydropyridines, we have amlodipine and nifedipine LA. These are the respective doses. Non-dihydropyridines, in addition to dropping the blood pressure, they also reduce the heart rate. Okay, because they also act on the myocardium, right? So for this group of drugs, right, do note that they are not for patients with reduced ejection fraction. Okay, I'm sure you have learned this in your heart failure lecture. Okay, so just pay attention to it. So if you want to start patients on this group of medicine, then make sure that they are not have ref. Okay, so verapamil, right, is actually approved for all variants of angina, so including effort angina, which is the one that we have been talking about the whole of the past 1.5 hours, and it is also suitable for vasospastic and unstable angina. I won't go much into an unstable angina, okay, but it is one of the spectrum of the acute coronary syndrome. Okay, then it can also help with supraventricular tachycardia. That means tachycardias that originate from the atrium. Okay, and also it helps with hypertension. Do note that they are CYP3A4 and PGP inhibitor, and so therefore you have to take note of drug-drug interaction. Okay, generally, right, if the patient is already on beta blocker, we try not to give non-dihydropyridine CCB, only unless the patient is on maximum doses of beta blocker, the heart rate is still very high, then we might use both together. Okay, but let's say if the patient already has heart block, okay, before starting on either therapies, right, then the more that we want to avoid the combination of these two drugs. Okay, if they are on two agents, right, then we need to monitor them closely using the ECG. Okay, so for today's purposes, okay, we have started lisinopril. We don't know how well he is going to respond to the lisinopril, and we have also started bisoprolol to help him with the symptoms. So therefore, I'm not going to start amlodipine yet, okay, because I'm not sure whether bisoprolol is going to control his symptoms adequately. Okay, so I'm not going to add so many things at one go to prevent him from having hypotension. Okay, so the next question, I will add ivermectin 5 mg twice a day, true or false? Okay. Okay, most of you decide not to start ivermectin, correct? I will do the same as well because we still do not know how well he has responded to the beta blockers that we have just started, right? Okay, good. So let's look at the content for ivermectin. Okay, ivermectin has a special mechanism of action. It acts on the receptor called the FANI receptor. I think you might have covered this in your heart failure lecture. And this will help to reduce the heart rate. Okay, you see there the repolarization is slowed. Okay, therefore the heart rate is slower. The place in therapy, right, for beta blocker is that okay, so Dr. Tan said that she did not cover ivermectin at all. Okay, so I'll go back a little bit. Okay, so it will it acts on this FANI receptor in the SA node. Okay, SA node is where the pacemaker of the heart is. Okay, here. Okay, so because of the disruption of the flow of the calcium ions, right? Okay, not calcium, sorry, the potassium ions, right? Okay, this caused the repolarization of the heart to be slower, and therefore there is a slowing of the heart rate. Okay, so let's say if the patient is already on beta blocker, maximum doses of beta blocker, or the blood pressure is very low. For example, the blood pressure is already 95. Okay, for example, the systolic is 99. Okay, if you increase the beta blocker further, and then it might drop the blood pressure. Okay, but ivermectin, right, it slows the heart rate, but it does not drop the blood pressure. Okay, so that's the place in therapy for ivermectin. Okay, it can be used as an add-on therapy to beta blocker or non-dihydropyridine if the target heart rate is not achieved or is limited by blood pressure, or it can be used as a monotherapy. For example, their blood pressure is low, or most of the time is because the blood pressure is low. In a small group of patients, it could be because they have, for example, uncontrolled asthma, and for some reason they cannot tolerate CCB, right? Then we might reduce the heart rate, okay, by giving ivermectin. Okay, it can only be used in patients with sinus rhythm. Why? Because it acts on the SA node. In patients who have AF, right, there are many different type of foci, that is firing chaotically in the atrium. Okay, so if you block the sinus node, right, it does not help to reduce the overall heart rate because the other foci are still firing. Okay, so it doesn't make sense to give ivermectin. Okay, so the doses, don't be too worried about it, but usually we start low, okay, especially for old patients, and then the maximum dose is 7.5 mg twice a day. Adverse effects are usually generally mild, okay. There's this something called phosphines that I want to share with you, is the experience of seeing light without light actually entering the eye. So I just want you to imagine, before you fall asleep, right, then you close your eyes. Do you sometimes see like lights in the dark when your eyes are closed? So that is how phosphines are like. Okay, that means there are these spots of light where, although the light is not entering the eyes lah. Okay, it can cause headache, dizziness. Some people say that it can cause AF. Okay, but anyway, we are not supposed to give them if they have AF lah. So they're generally mild lah. Most of the time is fine. Okay, next. So for this patient, I will not start ivermectin yet because I've already started bisoprolol, right? So I still don't know how well the heart rate has been brought down by bisoprolol. I'm not in a hurry to start ivermectin yet. Okay, what I will do, so the next question is whether I will start ISMNCR, that means isosorbide mononitrate controlled release. Okay, true or false? Okay, so almost 50% in each option. Okay, right now I would probably not start the nitrates. Okay, why? Let's have a look. Okay. Oh, okay, that's the last question. Okay, Nick is the first one. Is number 3. Second is mango. Third is first is Kay. Well done, congratulations. Okay, please send an email to Dr. Doreen Tan. Okay, and yep. Okay, let's go back to the slides. Okay. So nitrates. So what is the role? So what's the mechanism of action of nitrates? Is that it undergoes biotransformation, okay, and releases this thing called the nitric oxide. Okay, NO is nitric oxide, And with nitric oxide, it causes vasodilation. This will help to reduce oxygen demand because I reduce the preload, right? Preload means the volume of the blood that enters the heart. Okay, it reduces the myocardial wall tension and it reduces the oxygen, therefore reducing the oxygen demand, MVO2. It also increases oxygen supply because it causes vasodilation, especially stenotic vessels means that the vessels that has the blockages lah. Okay, so it causes vasodilation of the diseased vessels, and it also it causes vasodilation of the intracoronary collaterals. That means the other blood vessels that supply the same area of the blood of the heart. Okay, so that part of the heart that is the main vessel is blocked, but the other vessels that supply the same area, right? We can increase the blood supply by giving nitrates because they cause vasodilation. Okay, so what we try to achieve with nitrates, right, is that it is to prevent and to relieve angina symptoms. Common side effects are hypotension, dizziness, and headache. Usually headache, it is quite common, okay? But having said that, it will resolve with 2 weeks of therapy, and it can be treated with paracetamol. Okay, the contraindication with nitrates, right, is that you cannot, okay, I repeat, you cannot give it together with PDE5 inhibitors. What are PDE5 inhibitors? They are sildenafil, vardenafil, and tadalafil. What do these do? These medications are used in impotence, for erectile dysfunction, and it also helps to, it sometimes can be used to treat pulmonary arterial hypertension. Okay, pulmonary artery hypertension. So if you encounter these medications, right, okay, you must advise the patient not to use nitrates and any of these PDE5 inhibitors within 24 hours for sildenafil and vardenafil and 48 hours for tadalafil. Yes, so Dr. Tan said that Tanya Viagra, they sure know. Okay, yeah, but sometimes they are not called, they may not be, so Viagra is sildenafil lah, okay? There's also other brand names, Cialis, and I can't remember what's the other one. Yeah, okay. So sometimes therefore it's important to actually ascertain a good medication history of your patients. Okay, so chronic administration of your nitrates produces a state of oxidative stress leading to dysfunction of mitochondrial aldehyde dehydrogenase. Okay, what this means is that if you use it, right, all the time, okay, there is tolerance, okay? There is the anti-anginal effect of the nitrates is reduced or lost. Okay, therefore that means the patient has, so even if you continue taking, the patient does not respond to nitrates. Okay, this occurs only in long-acting nitrates, not the short-acting. Okay, and can be managed by maintaining a nitrate-free interval of at least 10 to 14 hours daily. So for example, if I take ISMN, right, isosorbide mononitrate, I will usually recommend the patient to take it in the morning, okay, because in the day, right, okay, you have physical activity, correct? You walk around, you need to climb stairs, you need to run after the bus, okay? So you will need the nitrates to be working in the daytime. So at night when you're sleeping, right, you don't really have that much activity. You do not need to have they do not need the vasodilation all the time when you're sleeping. Therefore, if your nitrate-free interval is at night, right, then it should help with this nitrate tolerance. Okay. So you must be thinking, what am I talking about, right? Because there's ISMN, ISDN. Okay. So this is what I'm talking about. GTN, glycerol trinitrate, GTN spray. Okay. So it can be in a tablet or in a spray. I will tell you more about this in the next couple of slides. Okay, long-acting ones will be GTN patch. We paste on the body, okay, to help to maintain the nitrate levels in the body. Okay, ISDN, isosorbide dinitrate. This is an immediate release tablet. Therefore, you have to give it 3 times a day. Most of the time, we give it 3 times a day. And the duration of action is relatively short, okay, 2 to 6 hours. Therefore, we need to take it frequently. ISMN is a slow release tablet, okay. Therefore, you take it only once a day. Okay, its duration of action is 8 to 12 hours, so you can take them in the morning. The patient can take them in the morning. Then at night, right, it will be the nitrate-free interval. So your ISDN, right, it is immediate release, so it can be given to patients who are on the nasal gastric tube. For example, if they have suffered a stroke or for some reasons they cannot swallow the tablet, okay, the ISDN can be crushed and flushed down the tube. Or you can give them GTN patch lah, okay? But most of the time, we don't give them GTN patch. We give them ISDN if they can take it orally or via the gastric nasal tube. But let's say if the patient has no problem with swallowing, okay, we do not crush this, but we can give this in the oral form. Okay, so far okay? Okay, Dr. Tan actually helped me with this. Cialis, Viagra, and Levitra. Very good. Okay, so those are the brand names of the PDE5 inhibitors. Okay, so some special notes about GTN. GTN is this short-acting nitrates. What it does is that it helps to manage the patient's angina symptoms. So, for example, if you watch TV, then sometimes like some drama, then they have some family argument or a heated discussion, heated argument. Then somebody will have this like chest pain, and then they look for this special bottle, and then the bottle has small little tablet, and then they're supposed to put under their tongue. Okay, this is what it is. Okay, sublingual means under the tongue. Okay, so if you put it under the tongue, because under the tongue there is a lot of blood vessels. Okay, it helps to absorb directly into the blood stream. Okay, so if you swallow the tablet, it will have to go through the GI tract. Okay, and it will go through absorption, and then it will pass through the liver. So by the time it enters the bloodstream, it's actually a lot slower, and the dose is a lot less. Okay, so if the patient have like acute chest pain right now, and then you want the patient to take the GTN to relieve the chest pain, right? Then you ask the patient to put it under the tongue. Okay, the onset is supposed to be within 5 minutes. Okay, when to use it? You use it when you anticipate there is an angina attack. Okay, for example, if you know that you are going to hike a mountain today, baseline, the patient has CTS, and he knows that if he exerts, he's going to have angina attack, then he can use it to prevent. But if the patient is already engaged in activity causing him to have chest pain, then you can use it immediately to relieve the current chest pain as well. Okay? When to use it? Use it at the first sign of angina attack. Do not wait until the severe pain develops. The medicine usually relieves within the pain in 5 minutes. Okay, if the pain is not relieved, okay, you use a second tablet after 5 minutes. If the pain continues after another 5 minutes, okay, then you take the third tablet. If after 3 tablets, still chest pain, the chest pain still doesn't subside, right? Then go to the hospital or call 995. Okay, so 3 tablets and 15 minutes. Okay, once so before the bottle is open, right, you keep it in the brown glass container and close it tightly. Why? Because once you open it, right, it is only good for 8 weeks. Okay, so do not open and transfer to other container. People say, oh, I want to keep it in an even smaller container. No need. So just keep it as in its original container. It is already very small. It's like smaller than my thumb. Okay, so ask them to keep it in their in the original container. They can put it in a pouch and carry them in a purse or a pouch wherever they go lah. No need to store in the refrigerator. And some male patients like to put it in their pockets, as in their pants pocket, right? Okay, because it's very close to the body, it is actually warm. It can cause the medicine to the quality of the medicine to deteriorate. Okay, so don't put them in the pocket. Put them in the don't put it in a pants pocket. If possible, put in a chest pocket. Okay. After the bottle has been opened before, right? Indicate the date on the bottle or on the label or something like that lah. Then within 8 weeks, still can use. But if they are not depleted, right, then they should be discarded and they should obtain a fresh supply of it. Okay, do note that GTN does not need a doctor's prescription. Okay, so if the doctor has prescribed it once, okay, subsequent supply may be obtained from a pharmacy without a prescription. Okay, it will be useful to share this with your patients because sometimes they say, oh, my doctor's appointment is very far apart. Okay, so I don't have an opportunity to top up the medication if I open it. Okay, so after they have opened, they have used it before, that at the next appointment, okay, they should inform the doctor when they used it or whether how many times they have used it, because we might think about adjusting the other medications to prevent attacks. Okay, so far? Okay, I'm running a little bit short of time, so I will continue. Okay, I'll be a little bit quick. But don't worry, if you have any questions, you can always just email me or contact me in one form or another. Okay. So trimetazidine is a cytoprotective drug. What it does is that it inhibits the beta oxidation of free fatty acid. So what it does is that it switches, it actually improves the efficiency in cardiac, in providing oxygen for the blood, for the heart. Okay. So the place in therapy is that it's usually used as second-line agent. So if they are not adequately controlled using beta blocker or calcium channel blockers or with nitrates, right, then you add in trimetazidine. It's usually given for patients that we really don't have other choices, then we add on. Okay. It's generally well tolerated. I usually don't see patients complaining of adverse effects from these medications. Okay, it's contraindicated in patients with severe renal impairment, and it's also contraindicated in patients with Parkinson's disease. Okay, if they have renal impairment, then we usually do a dosage reduction, but nonetheless, it's usually quite well tolerated, or if they have no other issues. Another drug that we use, and it is, and we don't use it frequently, okay, is that we use is ranolazine. Is in fact in my hospital we don't keep this medication. Okay, we keep trimetazidine, but then we don't keep ranolazine. The mechanism of action is not really known, but it's probably due to the inhibition of the sodium channel, resulting in improvement in the myocardial function as well as perfusion. The place in therapy, again, is similar to trimetazidine, is in the event if they are not adequately controlled with beta blockers or nitrates or calcium channel blockers, then you can add on ranolazine. Okay, you might want to initiate the dose at 500 mg twice a day, and then you can increase it if the patient does not have adverse effects. But generally, it should be quite well tolerated. Okay, it can cause constipation, nausea, dizziness, and headache. It may cause a small increase in the QTc, the QT interval. Okay, if the patients have concomitant QT prolonging drugs, you have to use with caution. It might need close monitoring. It competes with metformin for clearance, and hence it might increase the risk of increase the risk of lactic acidosis. So let's say if the patient is on ranolazine 1000, you limit the dose of metformin of no more than 850 twice a day. If it's renolazine 500 BD, then you can use metformin at any dose that is required. It can also cause a reduction in blood glucose. It may reduce HbA1c very slight bit, okay, without causing hypoglycemia. But while it is not indicated in diabetes patient, right, it might be clinically useful. So it's like an add-on therapy, like a good side effect of renolazine in patients who concurrently has diabetes. Okay, the last part of it is actually revascularization. This is actually the use of surgical, that means non-pharmacotherapy ways to actually open up the blood vessel. So you might have heard of this before, coronary bypass graft. In short, we might call it CABG, cabbage. CABG. That means they actually harvest blood vessel from the legs or from the below the armpit, right? Okay, and transfer this blood vessel to the heart. Okay, so it will bypass the part of the blood vessel that is blocked and supply the part of the heart that is not receiving sufficient oxygen. Okay, so that is bypass. Another way that we can help to open up the blood vessel is to use a PCI. PCI means remember how we do the coronary angiography? So we actually put a probe through the arteries, okay, and then we put in a dye to image where is the blockages, and then after we have located the blockage, right, the doctor will put in what's the thing called? It will put in a stent to open up the part of the blood vessel that is blocked. Okay, so the stent will hold up the blood vessel, and then the blood can flow through properly, so it will help to improve the patient's symptoms. But just to note that cabbage is known to improve survival, whereas PCI, right, is only it only improves the symptoms. Okay. Okay, I actually have a couple of videos, but in the interest of time, I will not be able to show the video in class, but you can view it at your own time. I will upload the video slides on your Luminous, okay, after the end of the lecture. So this will explain what cabbage is, and this will explain what PCI is. After PCI, just to note that, okay, in patients with stable coronary artery disease, depending on the type of stent that you use, don't be too worried about this, okay? So it can be opened up using a stent or open up using a balloon. Then the patients may need two blood thinners, DAPT, okay, two blood thinners, one aspirin, the other one with a P2Y12 inhibitor, okay, for a fixed duration. So it can be 6 months or 12 months, depending on the patient's risk of bleeding. For patients who have undergone CABG or those who only receive medical treatment, there's no need to use two blood thinners, okay? They only need one single antiplatelet, which as per the other patients, okay? But if they undergo a PCI and a stent or this is a balloon, drug-coated balloon, or if they use a balloon to open up the blockage, then they will need two blood thinners, okay? Okay, so this slide is probably the most important slide in your lecture notes. So this, if you understand and you can apply when to use which agent, right? Then you more or less have understood what I've delivered in this lecture. So all patients should receive antiplatelet, can be aspirin or clopidogrel, okay, depending on whether they have intolerances to aspirin or not. The place in therapy is to prevent all future events. They should be started on a lipid-lowering therapy, okay, to prevent future events, okay. The use of ACE inhibitor, okay, which I didn't include here. ACE inhibitor may be useful, okay, for patients who have hypertension, DM, reduced ejection fraction, or they have stable renal disease, okay. Beta blockers is the first line for anti-angina, okay, and we should target the heart rate of 55 to 60. The choice is guided by the patient's comorbidities. CCB, whether we use dihydropyridines or non-dihydropyridines, it can be used together with beta blocker or as an alternative to beta blocker. Again, the choice is guided by the heart rate and the blood pressure. Ivermectin, used as a second-line agent, can be used together with beta blocker or as an alternative to beta blocker if heart rate is high or is still high with beta blocker, or if the heart rate is high but the blood pressure is low, okay, then you can add on beta blocker, ivermectin, okay, because and the good thing is it does not affect the blood pressure. Nitrates, it helps with the symptoms, can be used together with beta blockers. It can reduce blood pressure. Remember, this cannot be used together with your PDE5 inhibitors, okay? Sildenafil, vardenafil, and tadalafil, okay? Do not use them together because it can cause life-threatening hypotension, okay? So nitrates can help to cause vasodilation, okay? And manage the symptoms, and you can use sublingual GTN, okay, on an as-needed basis. Trimetazidine and ranolazine is really second or third line because it's like when you have nothing else to give, then you give one of these agents. Okay, so the take-home message that I want to make sure you have is that CCS is due to the narrowing of coronary arteries secondary to atherosclerosis. The symptoms are brought about by an imbalance between the supply and demand for oxygen. The selection of pharmacotherapy should be guided by the presence of their comorbidities and the patient's response, as well as the patient's vitals. Vitals refers to the patient's blood pressure and heart rate. Okay. All right, I have come to the end of my session. Do I have any questions?
A couple of them we have class.
Oh, okay. All right. So
else on.
Okay, so if you have questions or anything, right, you can actually email me. My email is here, wee.xue.ting@kdph.com.sg. You can email me, or you can email Dr. Doreen and then have the questions directed to me. Okay, I will upload the slides for the video, okay, for you to read at your own time, to watch at your own time. Okay. Thank you very much.
Got question.
Oh, what's the frequency of chest pain for stable angina? So this is Haley's question. So Haley, there is no real frequency of chest pain for stable angina. So stable angina. So frequency is not a diagnostic criteria for stable angina, but usually is due to let's say if the patient exert him or herself, then and the patient has chest pain, right? Then we can call it stable angina lah. Okay. I hope that answers your question. Zhitian has a question. For consideration of ACE inhibitor or ARB, am I right to assume that ARNI can be considered as well? Yes. So let's say if the patient has heart failure, then we can use ARNI. But if the patient has no heart failure, right, then there is no indication for ARNI, then ACE inhibitor or ARB would be sufficient. Okay, ARNI is very expensive, and so even if patients who have heart failure with reduced ejection fraction, sometimes they are put on ACE inhibitors or ARBs and not ARNI per se lah. Okay, Rita-san has a question for Mr. PLM just now. Why was beta blocker added instead of increasing amlodipine dose? Okay, the reason being is that Mr. PLM, right, his heart rate was in the range of 80. Okay, it's still high. So we would want to start beta blocker first, okay, because we have already started ACE inhibitors, right, for Mr. PLM. And Mr. PLM also has proteinuria, correct? So the use of ACE inhibitor would be beneficial for his proteinuria. and it will help to control the blood pressure. Beta blocker at the same time can reduce the heart rate. Okay, so that will also help with the symptoms. So we might want to start. So if we have already started ACE inhibitor, we probably wouldn't want to increase the amlodipine at the same time on the same day, because we want to see how he responds with respect to his blood pressure with the addition of ACE inhibitor. Okay, I hope that answers your question. Anybody else? You're welcome.
Christine has another question.
Yeah. Wait, let me understand the question.
May speak lah, Zhiqian. Hey, where are you? Speak up, speak up.
Hi.
Hi.
Can I clarify for like calcium channel blocker, right? Because there's the DHP and non-DHP, right? And I understand that the DHP works more on the peripheries, but in the notes it mentions that we are aiming to induce coronary vasodilation. So I'm just curious, why is the focus not on non-DHP, but also like both DHP and non-DHP can be used?
Are you referring specifically to Mr. PLM's case?
No, just like in general, because in the notes it just says like CCB, right? Like there's no specific like saying like, oh, we should use non-DHP.
Okay. So in practice, usually we will start the patient on beta blocker first. Okay. So when we start the patient on beta blockers, then we'll watch the heart rate and the blood pressure. And second line, so after, if the patient is unable to tolerate beta blockers, then we will consider the CCBs. Whether the CCBs we choose DHP or non-DHP, it really depends on the patient's heart rate and whether patient has and how high the blood pressure is lah. Okay. Actually DHP, right? So DHP only reduces blood pressure. It doesn't affect the heart rate, whereas the non-DHP causes vasodilation as well as reduce the heart rate. So the question whether we will, so can I ask, your question is whether we should use CCB at all, or is it a choice between non-DHP or DHP?
Whether it's a choice between non-DHP and DHP.
Okay, so the choice between DHP and non-DHP is really dependent on the heart rate, because most patients will already have their have some beta blockers started. So if their heart rate is already like 61, 62, or already 57, then we probably wouldn't add a non-DHP, right? Because it will cause the heart rate to be even lower. So when the heart rate is even lower, right, it can cause the patient to be symptomatic in terms of like they might get tired more easily, they might have heart block, they may feel more breathless. Okay, so so whether to choose DHP or non-DHP is really dependent on the heart rate. Yep. And also, yeah.
Christine, are you asking about the principle that we say if we want to use dihydropyridines, we use it for periphery vasodilation, whereas for the non-dihydropyridines, we use it for the cardioselective effects, which is generally to reduce heart rate? Is that your question?
Yeah.
So why is it that for this particular setting of like angina or that we don't differentiate, is it?
Yes.
Okay, so I'll help Xueting out on this one because she doesn't know the background of what we've discussed before. So essentially, the all calcium channel blockers actually can lead to coronary vasodilation. All of them can do that. So the coronaries vessels, right, are special in that the dihydropyridines particularly can cause a little bit more coronary vasodilation than most other classes of agents. So generally, because of the fact that your angina usually occurs on exertion, right, so you're trying to actually keep the coronary vessels patent as much as possible. So it doesn't quite matter whether you use dihydropyridines or non-dihydropyridines for the context of angina, because your goal is not to reduce the heart rate, nor to vasodilate your peripheral blood vessels. So again, it goes back to pathogenesis of the condition that we're dealing with. Does that make sense?
Yeah.
Yeah,
Okay,
and then
thank you.
the other thing you must remember is that if the person is already on a beta blocker, you should not use which one? Which class of CCB should you not use?
DHP.
The non-DHP, yes, that's right. So particularly if it's verapamil, you should never use them together, right? Because the risk of heart block is going to be there. Okay?
Yeah, okay, thank you so much.
Okay, thank you, Prof. Tan, for helping me out.
Tomiko has a
Okay.
question.
Yeah, so Tomiko asked, is trimetazidine superior compared to ranolazine? No, there is no head-to-head comparison. So we can't say that one is more superior to the other. If you ask me why my institution doesn't keep ranolazine, to be honest, I don't know. I really don't know. But trimetazidine is actually very commonly used and is available also in the polyclinics. Okay, so it's more. So if we start the patient on trimetazidine, right, and it's logistically speaking, we can eventually discharge the patient from the hospital to polyclinics. Okay, so they can continue their therapy from the polyclinics.
I think today, Tomiko, the access to PCI is very, very easy. So most of the time locally, because of the way that our healthcare system is set up, the moment people have got angina, right, we literally send them to the plumber right away. So we affectionately call our interventionalists who carry out PCI our plumbers, because they reopen that plumbing at the heart vessel level. Okay, that's why we rarely use anti-anginal agents, and that's why there's not really a need to keep so many different types of anti-anginals in the formulary, particularly when we've got beta blockers and calcium channel blockers already. And this is my personal opinion. Please don't quote me on this, but trimetazidine is to me one of the Mickey Mouse drugs. Mickey Mouse meaning that you give people just to make them think that it's effective, but I don't quite believe in its therapeutic effects. Yeah. My theory has also been that trimetazidine is red, and so it makes a lot of our Chinese patients feel like, wow, it's very powerful. So there's quite a lot of placebo effects. Yeah, so that's my opinion. Okay, it's a Mickey Mouse drug.
Strictly Dr. Tan's opinion. Okay.
Okay, any other
anybody else?
questions, guys? No, so we've overrun by 20 minutes already. Better let you all go
I
for
see.
lunch.
Sorry. Okay, please have a good lunch, and the winner, please